Yes, it's my great pleasure to introduce our speaker for today. She and I have been exchanging emails for over the year, trying to see if we can figure out how to get together. But I shall say that Dr. Gabel was very, very busy and had lots of things going on, plus COVID hasn't helped and so on and so forth. But anyway, long story short, she's got a presentation that she's going to share with us. And I think, for some of us that are dealing with cancer in one way or the other, and radiology remains one of the key steps or procedures to try to deal with that as a sort of usually as a follow-on to surgery. So anyway, without further ado, I'm going to go through a little bit of Dr. Gabel's bio, and then I'll turn it over to her. So she serves as the medical director of radiation oncology services at Summit Health. She specializes in radiation oncology with a concentration in gynecologic, prostate, and breast cancers. She received a bachelor's degree in psychology at Boston University and then went to the University of Massachusetts Medical School and did a residency at the Henry Ford Hospital in Detroit, Michigan. Prior to joining Summit Health, she was a staff radiation oncologist at Robert Wood Johnson University Hospital in New Brunswick and associate professor at the Department of Radiation Oncology at Rutgers Cancer Institute in New Jersey, Robert Wood Johnson Medical School. She has held several roles within the Cancer Institute of New Jersey network, including medical director of the CINJ Oncology Group Clinical Trials and director of the CINJ Network. This position, she led endeavors to improve patient education, cancer outreach, clinical trial availability, and quality care initiatives at 19 New Jersey hospital-based cancer programs within the network. Early in her career, Dr. Gabel served as the director of radiation oncology residency program at Henry Ford Health System, and then later developed a radiation oncology residency program at Rutgers. Dr. Gabel was a recipient of the Henry Ford Health System's Caring Physician of the Year Award in 1997, the American Medical Group Association's Acclaim Award in 2003, and the Association of Residents in the Radiation Oncology's Educator of the Year Award in 2013. She has been featured multiple times in New Jersey's monthly top doctors listings. In addition to her current role at Summit Health, she is an adjunct associate professor at MD Anderson Cancer Center and serves as a quality council representative of the American Society of Radiation Oncology, a national multi-specialty council to identify and improve the quality of care. So when not caring for patients, Dr. Gabel enjoys spending time with family, riding her horse, and reading. And with that, Molly, doctor, I turn it over to you to fill us in on what's new in radiation and give us a little bit of background on it.
Molly, you have to unmute. And while you're doing that, let me just explain that Molly's sitting at a desk in her office where the computer does not have a video camera. So you will see her on her first slide. There you go.
Happy birthday to you. Hi, everyone. So as Larry said, we've been trying to put this together for months. I think he first reached out to me in January, to tell you the truth. And we kept putting it off for various reasons, hoping we could do this in person. So we're going to try and do this remotely, which tends to be pretty dry. The suggestion was made to do questions at the end, but please, I don't mind being interrupted. So if you have any questions, just raise your hand and they can unmute you, okay? Right. So this is a picture of me, silly, it's from Facebook, but it was taken the night we got town approval to open our first radiation oncology facility in in Berkeley Heights, in 2016. We now offer radiation services at Berkeley Heights and at Florham Park. Next summer, we open a site in Clifton, and then keep your eyes on the newspapers. It will be announced in January. There'll be 6 additional sites. So basically, we'll cover from Clifton down to southern New Jersey. So it's a very exciting time. So when Larry and I were talking, hold on a second. There we go. When Larry and I were talking, we thought that it would be helpful to kind of do a quick refresher course on what radiation is, and then I'll be giving examples, and I will be, to some extent, concentrating on prostate cancer because I thought it would be of most interest, but I'm up for any questions. So, just to start us out, most of you are familiar and have had regular x-rays, whether it's chest x-ray or you break your foot, and you know what the experience is like. I'm happy to say we have warmer gowns, but you're still on a cold table, and the x-ray goes through you. You don't feel anything, hear anything, smell anything, and it takes a beautiful picture of your foot or your lungs so that the doctor can figure out if there's any problem. That, when we use x-rays for diagnosis, is called low energy x-rays, and its value is to take that picture. When we use radiation to kill cancer, we use higher energy x-rays. Although the experience is the same, you don't feel anything, the x-ray beam passes through you, you're not radioactive, but because it's higher energy, it damages any tissue that it goes through, including both normal cells and cancer cells. And so if you or anyone you love or know has had radiation, you hear that there are a lot of number of treatments that are delivered, and that's because we give a low dose so that you are okay, but it's just enough to kill the cancer cell. So, and don't worry, this isn't going to be too scientific, but many of you are familiar. I remember learning about it, I think in elementary school, the double helix, the DNA or chromosomes that all of our cells are made up of. When radiation delivered at high energy passes through the tissue, it's strong enough to be able to damage the double helix, or the way I like to describe it, if the chromosome was a ladder, the radiation actually knocks some rungs of the ladder out. And so on a cellular level, it hurts the DNA, and it can also cause free radicals. And many people are familiar with the concept of free radicals. They actually cause cellular damage, and they can be prevented, for example, with multivitamins, et cetera. Now, the difference, the reason why radiation works, we didn't know. I mean, there were some very, very smart doctors in the 1950s and 60s that in those days we didn't have cancer screening, so people would present with a big tumor. And they found that if they divided the radiation dose into several smaller fractions or doses, the patient would be fine and the tumor would melt away. And I've actually seen handwritten prescriptions by doctors that say 5-week course of radiation, no other detail. Well, they were very smart. When I applied to residency in the 80s, we truly didn't know how radiation worked. But since then, and I was not the one that made this discovery, but I've done many of these tests on cells in the lab, we since have found out that our normal cells, everyone in this meeting, we have about 1,600 or 1,700 enzymes that repair the damage of radiation. So you've got enzyme number 1 that says, oh, that rung was knocked out, and it calls in enzyme number 2, which fixes it, and so on. In normal cells, again, there are about 1,600 to 1,700 repair enzymes. In cancer cells, there are only about half that, about 900. And all you need missing is one enzyme. So basically, those very smart people in the 50s and 60s were really taking advantage of the fact that tumor cells are not as sophisticated and they can't repair the damage at the same rate as normal tissue can. So what happens at the human body level? As the radiation goes along, the tumor starts shrinking and kills and dies. But also about 2 to 3 weeks into treatment, you start to notice side effects. not irreparable damage, but the tissues start to get angry from doing all that repair. It's basically analogous to when you have a cold, your nose swells up. So people can start to develop side effects, and the side effects totally depend on what part of the body that we're treating. After radiation is given, there can be permanent scarring, and that's why we have very well-established guidelines, which I'll get to later, to try and prevent or minimize that. So as I kind of briefly explained, or not so briefly, the side effects are very dependent on our repair. So in the blue box to your left, you see here the early or temporary side effects of radiation, which happen about halfway through treatment and last for about 2 to 3 weeks after treatment's done. You can notice skin reaction in the area that we're treating. Actually, and we'll get into the technology, skin reaction is getting less and less common unless we are trying to treat a skin cancer or breast cancer, other superficial tumors. Everyone gets mild fatigue. Again, it depends on the site and the volume of tissue, but imagine trying to fit in radiation and driving to radiation and finding parking. At least we've got that covered here, but it's stressful. You have to say no to your work if you have to leave early. You have to say no to friends, oh, I can't have lunch in the next 6 weeks, etc. And it really kind of makes it hard to forget that you have cancer when you're coming in every day for treatment. So that takes a toll. But also the repair takes a toll. And most patients describe it to me. The ones that are more engineers say, Dr. Gabel, I feel about 80 to 90% of my normal energy level. And more practical patients describe it as day 8 or 9 of what we used to call the 2-week cold, where you're back to work, if it weren't for COVID, you're going out to dinner, but you're not going to run a marathon. And then specific local side effects depend on where we're treating. The permanent side effects are basically, the medical term is fibrosis, but scarring. So it's possible, particularly if your physician doesn't follow the guidelines, which most do, you can have, for example, if we treat the breast, it can be firmer than the untreated breast, to give an example. And it can also decrease blood supply. And this is important for prostate cancer patients in terms of erectile function. And so we work very hard to protect the vascular structures. Now, the dose we give of radiation depends on how much tumor there is. So if someone has had surgery and the tumor is removed, then we're just worrying about a rogue cell that may have gotten out. But if someone has tumor that hasn't been operated on, we want to give a higher dose so that we totally annihilate it. Patients, for example, who've had surgery and need radiation, they may only need 5 weeks because they need a lower dose, 4,500 centigrade. But patients who can't have surgery or choose not to have surgery, such as head and neck cancers or prostate cancer, they need several more weeks of radiation. So over time, I gave you the historical perspective back in the 1950s, but really a lot has been happening in the last 20 years. For example, the first real radiation machine was called Cobalt 60, and cobalt is a radioactive isotope. So there was a ball of cobalt in a machine, and we just opened the jaws so that we could expose patients with cancer to radiation. Those basically wound out by the 1990s, although I remember training on a Cobalt machine, and it's actually the only radiation machine I could run because it was pretty simple. Now they're very high tech, and Except for very specialized centers, almost everyone has what are called linear accelerators. And all that means is that we generate radiation, we convert electricity to actual X-rays in a machine that is rather big. Now, over the past 20 years or so, we have gone from basically designing a circle or a box that's directed at a patient, we treat everything in the path, to being much more what we call conformal or precise, so that we're treating just the tumor or the organ that we want to be treating. We also, thanks to technology, are able to do everyday real-time mini CAT scans to make sure that we're treating accurately. Over the past 4 years, we now have data that it is safe and has the same cure rate to give faster courses of radiation, which is important whether or not someone is working for the reasons that I talked about before. And then, of course, in 2016, Berkeley Heights opened up. That was meant as a joke, guys. Okay, so before we start radiation, we do what's called a treatment simulation, and that literally simulates the treatment. So we have a patient come in for a CAT scan, which is in our department, and if we've given them any preparation instructions, they are to follow them. For example, if we're treating someone in the pelvis, we will ask that they come in with a bladder partially full. But for other sites of the body, we make what's called a cradle or a form or a mold. And that is to help the patient just relax like a wet noodle, like you see on the left here. And it really helps the patient hold the same positioning day to day. I personally think that the physicians should be present at the time that this cradle is being made, because it's probably the most important part of the treatment planning system process. So before we actually deliver the radiation, we have the patient in that form, and then we do a CAT scan, usually in 2-millimeter slices or cuts. After the patient leaves, the doctor draws all the relevant anatomy and hands it off for treatment planning. So that is called remote treatment planning, because the patient doesn't have to be there. About, depending on the type of treatment, but 2 to 5 business days later, the patient comes back and starts their treatment. This slide here shows you, on the left is actually inside the head of the machine, and you can see the yellow or the X-rays coming through. And then we have, on the right, you see lead or lead equivalent leaves that actually shape the field, so that we're not treating just a box or a circle, and we're able to protect structures. This is an example of what I was talking about earlier. In the old days, if you look at the top black shape, even though it was shaped, the strength of the beam is the same. Everywhere black gets the same dose of radiation. Probably in 2001, and it became nationally kind of the standard in about 2004, we began to develop what's called intensity modulated radiation. And what that does, if you look at the orange box, it's the way I describe it to patients, it's as if I put a piece of graph paper into the beam, and I can black out some of those squares so that we are avoiding structures. And so the top box in the white, you can see how some of it's very, very light gray. This is an example of prostate cancer. So here I'm trying to protect the rectum, which is a midline structure, but it gives you an idea of how technology has helped us get much more specific and conformal. But sometimes simple radiation works best. We don't always need the high-end, longer time on the table treatment option. So for example, this is a patient of mine, actually 92 years old when I treated her, and she presented with a rather large skin cancer on her lip. So we treated her with just a simple plan And as you can see, she had a complete response with no real side effects. This picture was taken 2 weeks after she finished treatment. But often more complex is better. So I already kind of bored you with the 3D regular radiation the way it used to be versus IMRT. The downside of the 3D, which is on the left, is because we're treating such a bigger area. When I first started treating prostate cancer patients, for example, I would counsel them that they would be peeing every half hour to hour, and that was pretty accurate, or getting up 5, 7, 8 times at night. But also, they developed diarrhea and incontinence due to rectal discomfort, and it was very common for men to be impotent after radiation. With intensity modulated radiation, you can kind of see on the right side that this is kind of conforming to the actual prostate gland. And now I tell patients that half to 2/3 may have more frequent urination. There's only about a 10% chance of rectal discomfort, no diarrhea whatsoever, and thankfully the impotence rate is lower. This is a little video that I made probably about 3 years or so ago, because I found when I was counseling patients, it's hard to conceptualize what intensity modulated radiation is. So this is one of my patients. So picture him lying on the table, and the machine is moving around him 360 degrees. So it's almost like we have an infinite number of fields, so to speak. And this just shows, the black shows where the radiation is going, and you'll see the leaves move as it goes around the patient. So that's just an example of what intensity modulated radiation is in reality. Now, you can take intensity modulated radiation and make it even tighter or even more conformal. And some cancers can now be cured with what we call, you might hear about radiosurgery, or it's also called stereotactic radiation. And that can be used for cancers that are relatively small, that even though I told you we need to divide the dose up, but because of where the tumor is situated, the person doesn't have to have surgery. We can basically give it a very, very high dose, either in 1 fraction or in up to 5 fractions, and annihilate it because of where it's located. So this picture here is of a patient with lung cancer who's relatively elderly. I believe this patient is not my patient. I believe this patient was 82, couldn't have surgery due to COPD and asthma that he had. The risk of biopsying this would be pretty great because it's hard to get a needle to it without collapsing the lung. And so we watch it on X-ray, and it grew. And so we treated it, and I believe this patient got 4 fractions and is alive and well at this time. This picture is from probably about 2 years ago. We also use this stereotactic radiosurgery for patients with spinal cord tumors or brain tumors. Now, I talked a little bit about the technology and that we don't what we call beam on or deliver radiation unless we are sure down to the millimeter that it's going in the right area. So underneath where it says no way is what we doctors do at night. No, we're not golfing. But what we do is every day for every treatment, we compare the image from today, so Tuesday, with the image from the original treatment planning CAT scan. You'll see a darker gray box up in the corner there. And when I moved it over this patient, you could see that due to stool or gas, his rectum moved right into the radiation field. So this actually wasn't treated, but the therapist kept the image for me to see, to say, hey, Dr. Gabel, you need to counsel this patient more about maybe a low-gas diet. In comparison, the next day, we did that, and it was absolutely perfect. So that's the reason why we image every day. The therapists usually make these determinations themselves. Sometimes we frustrate patients by saying we need to fill your bladder a little bit more, or you have a little bit of gas in your rectum. It's something patients wouldn't know. So going back to our timeline, one other thing that came in, and it actually started in the 1990s, mostly at designated cancer centers, but now it's required, which I'm very happy about, and also insurance companies are requiring us to follow evidence-based guidelines. It's very analogous to what's happening with COVID. We all wait for what the CDC tells us to do. So within radiation and cancer in general, we have evidence-based guidelines on, based on the patient's tumor, what would be the best treatment option for them, and we counsel based on that. So this is just an example of material that I prepare for my patients with prostate cancer, because prostate cancer, when presenting early because of screening with PSA, is one of the rare medical conditions where your doctor gives you all this information and says, okay, do you want to just watch this and get your PSA every few months? Do you want surgery, or do you want radiation? That's a pretty overwhelming decision to have to make. And so we just decided that it would help patients if we put a lot of the information I've already told you into a kind of 3-page executive summary for the patient, making recommendations of what I would do for that particular patient, all of which is based on evidence-based guidelines. But also, I mentioned that the permanent side effects of radiation can include scarring. And thankfully, over the past, now it's been about 13 years, we have some very smart scientists who have published, who have worked out what each structure in our body can tolerate. And not only that, it's not just that the spinal cord can tolerate X dose, but depending on what schedule I prescribe, what's safe to give to the different structures. And so this is incorporated into our prescriptions to protect the patient so that the incidence of any scarring is as small as possible. With any kind of cancer and with any kind of treatment, I think that patient education is probably the most important thing. First of all, a patient that is fully informed is going to be less anxious because it takes the fear out. But it also, in particular to prostate cancer, having patients come in with a partially full bladder is much more important than who their doctor is or where they get their radiation, because they're physically moving the bladder as it expands away from the radiation field. But we also give information when the patient finishes treatment. And this is something that in some of my work on national committees, this is soon going to be mandated by Medicare, that we not only give something like this that you see here, which are called discharge orders to the patient, but we also include what you see in the blue ink, a record of what dose we delivered. And so when we give this out to our patients, my male colleagues don't like the smiley face, but my patients get the old-fashioned smiley face. We tell patients to keep it in their record so that if they move to Florida or they move to Arizona, they can just hand this off to their doctor, and it's a record of what treatment they got for cancer. So that takes us to the end of treatment. The first question patients have, and I often notice that it starts about the second or third week of treatment, when all this is done, how do I know if I'm cured? Many cancers we follow with physical exam, occasional blood work, occasional CAT scans. Specific to prostate cancer patients, we're very lucky to have the PSA. And so this is just an example of something we give out to patients that shows how an average hypothetical patient will have their PSA decrease after treatment. But some patients, for example, patients with breast cancer, they need to have careful physical exams every 3 to 6 months with mammogram and ultrasound. It's all, again, worked out on evidence-based guidelines that are approved by the U.S. Task Force, which is the entity nationally that determines who should be screened for cancer and what the care after cancer is. So that takes us to the end for questions. We wanted to leave a lot of time for questions.
Okay, so Bill Tittle, you're first up.
Thank you very much. So my question is, I had prostate cancer, and I got to tell you, I chose surgery over radiation because I was concerned about the possibility of cell mutation. Can you speak to that? Was I wrong on that, or?
No, you're never wrong when you make the decision. In fact, I counsel patients that there are a host of things that go into that decision, and you need to make the decision that you're comfortable with. Low-dose radiation can cause cancer. It can happen in about 1 out of every 10 to 20,000 people, so it's pretty rare. And if it happens, it does take 15 to 25 years to come to fruition, so to speak. So I have other patients that made the same decision that you did, and I think that's totally justified. Just like some patients who choose radiation do so because they're totally turned off by surgery or don't want to miss as much work. So it's a very personal, private decision.
Just a quick follow-up. Do we know why, whereas normal cells repair themselves, cancer cells go away?
Because they don't have as many repair enzymes as normal cells,
Okay.
or their repair enzymes don't function properly. So if you think of, I mean, the reason why we all hate the word cancer, I mean, cancer cell is a cell that has lost the ability to stop growing. So all the other cells in our body, like in your earlobe, if a cell divides, it bumps up against another cell and says, okay, I don't need to divide anymore. What makes a cancer cell grow into a tumor is it's lost the ability or the sophistication to stop growing. And along with that, it's also lost the ability to do a lot of functions, such as repair the damage to radiation.
Thank you very much.
Mitch Erickson.
Yeah, thank you. I just wanted to actually ask two questions. First of all, this is kind of snarky. I don't know. Anyway, Alan King was remarking on how the radiation technicians always go into the other room behind the lead shield before they push the button. Can you explain to us why that happens? And then I also have a question on if you can go into some survival statistics over the past decade, say your career or even longer, just in terms of how much better we're doing.
Sure. So the answer to the shielding is twofold. He was talking about the low energy X-rays, but the reason why they're gowned up and the reason why nowadays they don't really go into another room, they go behind like a glass shield, is because that technician is probably doing 80 X-rays a day. And so over a lifetime, that could make them very sick. It's not just the risk of cancer, it's the risk of scarring of their lung, developing heart disease for female patients, breast cancer. So with radiation, we also, our therapists, have to leave the room and we watch the patient on video and we can hear them and they can hear us. For both departments, everyone who works in the department has to wear a radiation badge, which is monitored very closely. So the Nuclear Regulatory Commission has determined a safe dose that we can get over our lifetime in the field. I will tell you, I've been doing this for 30 years and my badge is always counted and I've never registered anything. But it is uncomfortable for cancer patients, and we make sure we explain that from like day one, that please, we can see you, we can hear you. If you feel like you need to sneeze or if you're scared, just tell us, we'll stop the beam, we'll come in, because it can feel very isolating. Then to your second question, which I think is what have survival rates done? Whenever I go, well, we don't go to cocktail parties anymore, but whenever I go to a cocktail party and I'm meeting someone, they ask me what I do for a living, and I say I'm a radiation oncologist, and they say, oh, I'm sorry, that must be so hard. And my answer, although I do treat, most of my patients have either early stage breast cancer or prostate cancer, but I do treat other cancers that are quite aggressive and don't have such a great survival rate. But my answer at the cocktail party is really true, that just personally, over the past 30 years, I have seen survival rates consistently increase, and I can truly say that 80% or more of my patients I'm treating for the cure, and I expect the cure. And that is in part due to the technology, but it's in part also due to clinical research. Again, just like we see with COVID, where researchers try and increase the survival rate without causing more side effects. I wasn't sure if that's what you were asking.
Yeah, more or less. It's just, medicine's getting better, and I just wanted to hear from the radiation oncology perspective how much better. So, that's a good answer, and thank you. And thank you for a great presentation, by the way.
You're welcome. My pleasure.
So next, our man in Seattle, Phil Apressis.
Thanks very much. I appreciate the information you've given us to date so far. One question is the intensity modulated radiation used in 3 dimensions? In other words, is that, if one were to have a side view of that small tumor you showed in the prostate, is there also an intensity gradient to the radiation applied, or is that strictly in 2 dimensions?
That's an excellent question, and it is 3 dimensions. And actually, because of all that leaf motion that you saw before a patient is actually on the table being treated, our physicists test it on a 3-dimensional, what we call a phantom, which is basically the shape of a body with radiation detectors, to make sure that what we prescribe is actually delivered.
And I guess the follow-up would be, how fine are those density differences? In other words, what's the dimension of them? Are they a millimeter, half a millimeter, 1/10 of a millimeter? Well, if one were to have a picture of it.
Yeah. So most places in the country will have 2 different types of machines. When we're treating standard non-stereotactic radiosurgery, they're 5 millimeters each leaf. And when we're doing radiosurgery, it's much smaller. It's, depending on the machine you buy, it's either 1 millimeter or 2 millimeter leaf.
Thanks very much. Appreciate that.
Next, Larry Cunningham.
Hi, Dr. Gabel. 2 questions. One, I think is specific to prostate cancer, which is that I've had relatives who have undergone something called insertion of radiographic seeds I'm just curious in how how those would operate relative to radiation, the way you described it, or some other way. But can you talk a little bit about what this radioactive seeds technology is, and how is that going out of favor or in favor or whatever?
Again, good question. So seeds were very popular in the 80s and 90s. I've done many. And there are two different types. Let me just talk about the more common type, where a patient is actually brought to the operating room, and in the operating room, through the skin, we insert little radioactive pellets into the prostate gland. The patient goes home, and over the next, we choose a radioactive isotope that has a short half-life. So usually it's 72 to 74 days. And so over 3 months, those seeds just kind of leak out radiation and treat the prostate gland. And then eventually they wind down so they're not producing or shedding radioactivity anymore. There's also, that is called low dose rate seed therapy. There's also high dose rate seed therapy, which is insertion of catheters through the bottom, kind of behind the scrotum, that go into the prostate tissue, and then with a machine in the department, we can connect those catheters to a channel where a radioactive seed does it, over 5 to 10 minutes. The more common low dose rate seeds kind of went out of favor because of clinical research. We found that it really didn't do much more than watching and waiting. It was used for very early stage prostate cancer that wasn't very aggressive. I personally, when I came to Summit, chose not to offer seeds for two main reasons. Number one, you should do it for a living, and that's all you should do. To be good at it, I believe, it's just me being stubborn, but I believe that you should do at least 50 procedures a year before you do it on your patient. But more importantly, just from my clinical experience, about 30% of patients who get the seed implant, because the seeds are giving out radiation over time, and because most of that radiation is given out during the first month, about 30% of our patients landed in the emergency room unable to pee, which is very traumatic, have to wear a catheter for a week, and it goes away, but it really turned me off of that. We've really gone to the high dose rate, and it is used, obviously, I just described how it's done with a catheter, so you can't do it on an ambulatory outpatient basis. So it is used in hospitals, and right now clinical research is looking at, for patients with very high risk cancer, should we do external beam and then boost it or give some additional with brachytherapy? And so for patients like that, we do refer to a hospital system. I personally prefer Mount Sinai, so I would have my patients go there because he does it. That's all he does.
Second quick question. This is kind of a crazy question, but how would the amount of radiation in total at Chernobyl compared to the guidelines that are in the US for, I'm pretty sure there's probably off by 3 magnitudes or 4 magnitudes, but just a quick answer on that?
Yeah, it's actually thousands of magnitudes. So when there's a radioactive accident, there really is a ground zero. And then there are concentric rings. And if you're in ground zero, you basically explode like a bomb. But as you get further out, even a mile out, you can get be totally immunocompromised, or you can get horrible nausea and diarrhea. So it all depends where you are in relation to the accident.
Okay.
Good, thank you. John Tomaszewski.
Yes, hi, that was an excellent, I think it took some of the fear of radiation that I've always had out of my mind. But my question is, are there any organs that you cannot do this on?
Yes, I love these questions. Yes, well, yes and no. So each organ has its tolerance. So believe it or not, nerves, the spinal cord, is actually more resistant to radiation, and we can get away with it. But I talked about how there are guidelines for what each organ can get. So for example, the bladder, or a portion of the bladder, can comfortably get 7,000, no problem. Rads, or centigrade, which is our unit of measurement. The bowel, before getting diarrhea, can get 4,500. What I worry about most is actually the kidneys. They're probably the most sensitive. So we want to stay under 1,500. So kidneys are things that I worry about. I also worry a lot about the heart, because when I'm treating breast cancer, in the 1970s, I told you all that great data about how patients with breast cancer were cured with the 5-week protocol, but they didn't have imaging. And so without even realizing it, they were treating part of the patient's heart. Now, you could say, look, they cured the cancer, but what we found was in the late 70s, all those patients that were treated in the 60s, at the time, many women didn't work. At the time, there was probably about a 30% rate of smoking among women, and most of that was social, not every day, and they had double the risk of heart attacks. So we are incredibly cautious about the heart, particularly the left heart, so that we don't cause coronary artery disease.
What about the brain?
The brain, again, can take so at standard fractionation, it can comfortably tolerate 5,000, but we also protect certain structures like the optic nerves and the brain stem, where the brain goes down into the spinal cord. But all the different parts of the brain even have been worked out to that. So we draw that in our planning, and it's in our prescription. And before we approve it, our planning staff has to get under the dose that's in the prescription.
Thank you.
Mm-hmm.
Okay, I'll slip in a quick question here. We all follow our PSA pretty closely, I guess, especially if we've ever had any kind of cancer. But isn't it true that PSA can rise for other reasons besides cancer cells?
Yes. So normal prostate tissue makes PSA. So if you were to check a PSA on a 25-year-old, it's going to be 2 or 1.5 or 2.5. And so also, as we age, the prostate gland enlarges a little bit. So a 40-year-old prostate gland is going to be smaller than a 60-year-old. So that is why when your primary care physician checks your PSA, and every decade he says, no, it can be normal up to 4, or it can be normal up to 4.5. He's doing that because the normal tissue is going to make PSA. Prostate, as we know, prostate cancer cells also make PSA. And so we look at the volume of the prostate itself in relationship to the PSA and do a calculation that, ooh, this is higher than we'd expect just from an enlarged prostate.
Are there other kinds of diseases that can cause a rise in prostate?
The only thing I've really seen is some patients, and usually they have quite significant symptoms. You can get inflammation of the prostate gland, just like, laryngitis, prostatitis, anything itis. It just means inflammation. And so you can have inflammation of the prostate gland. And if I suspect that, then we usually treat the patient with antibiotics and then repeat it.
Yeah. Okay, thank you. Ron Wenger.
Hi, I heard a couple of days ago, it was on the news, and it caught me by surprise, so I didn't catch the details. But I think they said something like prostate cancer is still one of the most difficult cancers to treat. Is that really still true, and why? I'm
not sure what they were talking about. But most prostate cancer, because of PSA, actually is early stage and is curable. So when we talk to a patient with early stage prostate cancer, if they just watch it closely, they have an 88% survival. And if they get treatment, that moves into the low 90s. Now, some people don't seek medical care. Some people don't have PSAs done routinely, so it's not caught as early. Or some cancers, remember I was talking about the repair, some prostate cancers don't make PSA because they are so high grade, so unsophisticated, they've lost the ability to make PSA. So yes, for someone who has a much more aggressive cancer, then we don't treat with just one modality. We might offer the patient surgery followed by radiation, or radiation combined with hormones. And prostate cancer, maybe, it's hard to say because I didn't see the report on TV, but they may have also been talking about treatment options for prostate cancer, and there really isn't any chemotherapy that really has worked. We've tried just about everything. Right now, the big deal, though, and I would say for the past 2 years, is there's what's called immunotherapy, where basically it's a medicine to help your body fight it. And that's actually very exciting. And I've been lucky enough to have a couple of patients who've had bad cancers that they've been able to go on immunotherapy. But perhaps on the TV, they were referring to the fact that there's no magic pill for prostate cancer.
Mm-hmm. Thank you. Rick Smith.
Yes, Dr. Gabel, very interesting discussion, very understandable for a layperson like myself. In general, during the past 2 years with the COVID outbreak, have you found that patients were canceling or postponing their radiation treatments, or did Summit Health have to maybe cut back a little bit on scheduling the radiation treatments for safety concerns with COVID?
No, which is why it's good that you can't see my face. No, we stayed open. Because we're not going to delay someone's cancer treatment. So in general, any cancer surgery, screening, such as PSA tests, but also colonoscopies, were allowed to continue. So we were open throughout. I have noticed, I hate to be negative, but in talking with colleagues, I have noticed an uptick in cancers now as people have, not so much this month when we're almost in lockdown again, but where over the fall and the late summer, as people got more comfortable going to the doctor or getting their mammogram, et cetera. So actually the incidence is really rising, but I think if we were to average it over the whole year, the COVID year, it probably isn't increasing. It's just delay due to COVID COVID delaying the diagnosis.
Okay, thank you. I didn't mean to imply Summit Health would, postpone treatment. I was just wondering, the hospitals were reporting that, a lot of patients, were kind of putting off elective surgeries or necessary surgeries, and yeah.
Sometimes patients do, but in general, no. And I've talked to my colleagues at the hospitals, the same thing. They don't want to, that's what I mean by we don't want to delay treatment. The patient doesn't want to. And we do it safely. In the early days, if we had someone that tested positive, they had to do the usual quarantine, and then we treat them at the end of the day, and we had these bleach and UV lights, and we do what we call terminal or end of day cleaning. But actually, the therapists have always had to clean all the surfaces with bleach, which actually happens to kill COVID. So it hasn't really changed our day-to-day functioning all that much.
Well, that's good news. Thank you very much.
Mm-hmm.
Okay, Ed Atkin.
Yeah, Dr. Very informative talk. I have a question. My mother had continuous or cantankerous horns on her face. Is that a form of cancer, or what is that?
I don't know. She had horns.
Horns, like they look ugly.
Horns?
Like blue horns.
So that could be something that could develop into cancer. It's actually, the medical term for it is called keratosis, which is
Keratosis,
in
yes.
layman's language. Yeah. So that usually can just be removed. I have them particularly on my hands and neck because I spent time in Africa before, as a child, before suntan lotion was really used.
Yeah,
But
when
it's
they
very
remove-
common.
It's not done by radiation or what? They seem to like burn it off or something.
Yep, yep. And then if it were to develop into a cancer, then there are a couple of different options. There's topical chemotherapy, just removal surgically, or radiation. But keratosis is I would say that, I would gander to say that every single person in this meeting probably has it somewhere from sun exposure.
Yeah, correct. Okay, thanks.
Or Bodell.
Yes. Probably the most lethal cancer is pancreatic. Is radiation therapy putting out any hope for a cure?
Radiation can be used, but yes, pancreatic cancer remains one of the most deadly. I think of pancreatic cancer and then some brain tumors, like what Mr. McCain had and Mr. Kennedy. With pancreatic cancer, it is a really nasty beast. The way it behaves, you know, each type of cancer has its own personality. The way that pancreatic cancer behaves is that no matter what you do, surgery or radiation, it comes back locally, and it also can spread. Right now, the data has not really, the needle has not moved since I started training in the late 80s, that if someone can have surgery for pancreatic cancer, then the survival is 10%, which is the worst. And if they can't, then it's less than that.
Steve Barley.
Thank you, Dr. Gabel, for a wonderful talk. You showed a picture of an elderly patient who was treated by radiation for skin cancer. Is radiation an appropriate treatment for squamous cell carcinoma and or melanoma?
Yes, for squamous cell, no for melanoma. I mean, we can, and we have palliatively, but for melanoma, so we, and I won't get into a long answer, so don't worry, but basically skin cancers can be divided into the less threatening, which are basal cell and squamous, versus melanoma. Its personality is to spread and come back years later. So for that reason, with melanoma, the treatment of choice is surgical excision, so we can see how deep it is. If we do radiation, we can't really tell how deep it goes. And then also, most of the time at surgery, we also sample the lymph nodes to determine whether chemotherapy or immunotherapy is needed.
Thank you.
Tom Tobish.
Yes, thank you, Dr. Gabel. It was an excellent presentation. I'm a survivor of prostate cancer. I was diagnosed just about 8 years ago, and we decided to take a three-pronged approach, with one which was treated with hormones. As I understood it, I was diagnosed in December. That started in January. As I understand it, that was to slow the growth of the cancer. And then I had seeds implanted in March or April. And then in June and July, I had radiation. And it's 8 years ago. It's almost 8 years ago. And my PSA is like 0.02, and I get it checked every 6 months, I guess it is. But what I'm interested in, you didn't say much, you did mention the hormone treatment, but that was actually the worst part for me, because within 2 weeks I had gained 15 pounds, keeping the same the same diet and continuing to exercise. And I got these hot flashes, which were terrible. So I'm just interested if that still is a part of any of the regimens that might be treated.
Yes. So first of all, you're the poster child of what we were talking about, technology helping you.
Yes.
So we went on it with the multimodality approach with the brachytherapy. So I'm very happy to hear that. In terms of the hormones, I kind of went quickly through the educational documents, but that's something we really want our patients to be sure of. Depending on the type of cancer you have, you may need hormones for 6 months or for 2 years or more. I tell my patients that the big side effects, the biggest side effect is complete impotence. That happens in 100% of men. And that's a big shocker. And actually both at Summit, but also at MD Anderson, we're about to publish a paper that after patients hear, look, if we do the hormones, you're going to be impotent. About 40%-ish, 38% choose not to have hormones. The second most common side effect is hot flashes, and I tell people that happens in about 75% of cases, and they can be quite bothersome, which leads to side effect number 3, which can be fatigue, particularly if the hot flashes happen at night. But it's very similar to a woman going through menopause. You know, when the hormones go away, your body just says, okay, the metabolism slows down, you can gain weight, the hot flashes, etc.
Yes, I got a lot more empathy for my wife and for other female friends that I have after I went through this experience.
Yeah, it's very difficult. I'm glad you're feeling better.
Oh, I mean, it's been great. I mean, it's almost 8 years, and I at least as far as PSA is concerned, it's excellent. It went, when I was diagnosed, I went from like 4 to 7 or 7 something in 6 months, whereas previously it, you know, might have gone up a couple of tenths per year. And that's when I had done a biopsy, and that's what led to the other things. But I would have happily done without the hormone treatment, you know,
Yeah,
knowing more.
it's hard. It's hard.
Okay, so it's
2 more.
11:34. Dr. Gabel, can you stay for a few more minutes? We have 2 more questions.
Yes. Yes.
Okay, fine. So let's take Ron Hoke next.
Thank you very much, Doctor. That was a very interesting presentation. Are there any new radiation therapies coming down the pike that we might look forward to in the near future?
Not really. No. Because there have been so many changes recently. So particularly the intensity modulated radiation really has cut down on toxicities or side effects. And then also the shorter course radiation has made a big quality of life change for our patients. I look toward the immunotherapy or chemotherapy as being the next big wave of improvement for prostate cancer.
Thank you very much.
Okay, and finally, the last question, John Mikeda.
Thank you.
Oh, sorry, I hit the wrong button. You have to unmute again, John.
Thank you, Dr. Gabel. Very informative talk. My question is on a proton therapy as used in the case of prostate cancer as opposed to the electromagnetic radiation therapy. Do you have any comments on that?
Absolutely. Actually, before we opened here at Summit, I spent time, since we had a proton unit where I came from at Robert Wood. There's also another proton unit in Somerset run by amazing doctors who I already had a relationship with. And so because we could see that possibly insurances would start to cover proton, I spent 2 days there. What proton is completely different physics. So the way I like to describe it, it's like a smart bomb. So rather than just flashing through your body, it goes into your body and then kind of explodes or delivers its dose at the middle of the body. Okay? That's just the way it's programmed. So the only downside of proton therapy is that it takes, in terms of land, it takes about 4 football fields either subterranean or actually on the surface. And it costs, hundreds of millions of dollars. As a result, the treatment course costs about $120,000, which is about, I don't know, about 3 times what standard radiation costs. This is absolutely proven for pediatric cancers and for spinal cord tumors, where particularly for pediatric cancers, earlier I answered a question about radiation-induced malignancy. And if you remember, I said, look, if low-dose radiation is what causes it, high-dose radiation is going to kill a cell rather than cause cancer. But it's the low-dose radiation that we worry about. And if we're treating a child, then that 15 to 25 years is going to be during their life. And so it's very, it's standard of care for children. For prostate cancer, it has the exact same cure rate and side effects as standard radiation, with the exclusion of second cancers. And so what we do is, if someone is interested in proton therapy, we call on their behalf to find out if their insurance will cover it. I have had probably 3 or 4 men that have been wealthy enough and really wanted it, that could pay for it themselves. And I am happy to say that insurance companies are starting to pay for it a little bit more liberally. But again, they look at the same data as we do, and they say, I'm not going to pay $120,000 for the same outcome as something that might cost me $35,000.
Okay, thank you. Well, I said that was the last, but Mike Katz just wants to slip in one question. Go ahead, Mike.
Okay, thank you. Doctor, thank you for a great presentation on a subject which I'm sure is very difficult for many of us. My question is, what is a Cyberknife?
Oh, okay. That's an easy one. Okay, so Cyberknife is a brand name of a radiation machine. Essentially, in actually the world, not just the United States, there are 3 manufacturers of radiation equipment. There's Varian, Elekta, and Cyberknife. The Cyberknife machine was first designed to treat lung cancers, radiosurgery, like the picture that I showed you. And then they learned, oh, I can treat prostate cancer with that too. When we started here, the CEO, who's very forward-thinking and funny, said, Molly, why don't you get a Cyberknife? That sounds cool, because you hear it advertised all the time. And I actually thought, hey, if I'm given a blank check, I'm going to look into it. I chose not to buy it because you can't treat all cancers on it. So I would be doing a disservice to the patients with breast cancer, et cetera, just due to technical reasons that we can't. But also you need to, basically you're paying $1.5 million and you have to sign a contract that you're going to advertise on the TV or radio. And I'm not very proud of it, but it's a great machine. So we have, well, there are probably 6 or 7 throughout the state. We have them in this area as well. I mentioned that different brand name, that what I chose to buy is termed Saber. Again, I think guys came up with this, like a saber-toothed tiger. And that is actually delivered on our machines, but it's the same outcome. So kind of Saber and Cyberknife are used interchangeably.
Thank you.
Like Kleenex or whatever brand of tissue, you know.
Yeah. Well, thank you. So Larry, you're up.
Okay, well, we usually try to acknowledge the assistance that we get from our presenters. So we've got the first thing, which is we call the Old Guard salute. So Paul, if you will unmute everyone.
Okay, everybody.
Yay.
All right.
Salute.
And the second is a certificate, as you saw at the beginning of the meeting back at 10 o'clock. But this is certificate of appreciation for you being able to go out of your way and giving us this presentation. We got a lot out of it. I see a lot of people were quite interested. And, you know, one way to always measure the interest level is to look at the participants at the beginning of the talk and the one at the end. And if it's starts off with 100 and the end it was 1, it's probably not so good. But in your case, the numbers were pretty constant. So,
Yeah, right.
Doctor, again, we really appreciate you taking the time out.
Very
And
informative.
I
Thank
really
you.
enjoyed it.
Right. Well, we hope we'll never see you in your office.
I hope so too. No
Maybe at a
offense.
cocktail party.
Yeah, right.
So anyway,
Okay,
thanks again,
great.
Doctor.